Then can you see the arrow moving?
Yes, yes.
Yeah, it's
Oh.
amazing. Yeah.
Oh, brilliant. Oh, I'm really sorry. So these are the slides anyways. I will get them emailed to you anyways, but good. So basically this is what I said I would cover. So a mixture of topics, medical topics, and then we'll end up with resuscitation in pregnancy. What I won't be covering today is, let me minimize that, is hypertension and diabetes, but I'm happy to organize another session for that. And then I talked about preconception counseling, and this is why it's important. And again, apologies that this is reflected of what's happening in the United Kingdom, but I think it's a mirror reflection of what's happening elsewhere. But what we've seen is the rise in mortality in women during pregnancy or up to 6 weeks after they birthed from the pandemic onwards. When they looked at this analysis in the United Kingdom, they realized there's a constellation of things contributing to these deaths. So and some of them, what we're seeing is a rise in obesity, overweight and obesity. We're getting pregnant, women are getting pregnant at a much older age. There's a lot of, because improvements in treatments and across a constellation of specialties, women are living longer, so getting pregnant later. But also what we're seeing is we have a lot of people. So I'm a doctor in the NHS, and the National Health System, I struggle to navigate it sometimes as a doctor myself. So I cannot imagine what it's like for women coming from abroad who don't speak English. So we looked into that. So there's a lot of women from ethnic minorities here, and a lot of them are dying because of that. What we also see in the United Kingdom is a lot of domestic abuse and unemployment. So those are sort of risk factors that might mean that women struggle to access health for different reasons. So it's just being aware of that and try to address them. And then when we look at the causes of death, so the top cause is thromboembolic disease, so blood clots, followed by deaths due to COVID-19. And then in the third place, women with cardiac disease, followed by women with mental health condition, whether it's, depression, anxiety, personality disorder. But essentially in here, preeclampsia is at the bottom of the causes of mortality, but we're seeing a rise on the rest. Sorry, the previous slide, this was the causes of death on the previous report. So cardiac disease used to be at the top, but that's changed, and now what's at the top is thromboembolic disease, particularly in the first trimester and in the third trimester. And I'll talk on to that might be. So what happens in the preconception counseling? So ideally, I urge professionals, so anyone who's got any medical problem, who's wanting to become pregnant, should have a chat about, okay, what does pregnancy mean to my condition? So how does pregnancy affect my disease and the treatment of the disease, and vice versa? How does the disease affect the pregnancy? And then you need to think, oh, what sort of things could go wrong, and how can I limit, damage control, And I know we've got 2 patients, but for a healthy baby, ultimately, you need a healthy mum, okay? And a lot of what we see is that some women will get a positive pregnancy test and they'll be fearful, oh, I'm taking citalopram, for my depression. Oh, I'll stop taking it. So I'm taking, lamotrigine for my epilepsy. I'm going to stop taking it. And a lot of that is due to fear. But if we start to thinking of care of pregnancy before women get pregnant, we can work on a lot of these misconceptions amongst women. Okay. But we do see it's a common theme that stopping medications can lead to worse pregnancy outcomes. So it's something that we need to address before women get pregnant. So when I see women in the preconception counseling clinic, and if any of you come in for the summer school, I'd love to have you around in this clinic. It's a very nice clinic. So I take the history. So what condition do you have? And then I try to think, okay, what medications are teratogenic, and what do I need to stop and switch to a more friendly medication for the pregnancy? Do I need to ask them to take folic acid? Particularly women with antiepileptics, because they're at higher risk of neural tube defects, so they need to be on high dose folic acid, even before conception. You try to address things like smoking, alcohol, before pregnancy, and get them the right support. When I examine them, I'll have a look at, one of the things that you need to think about is the BMI, and, having a high BMI has got a lot of implications for pregnancy, will increase your risk of blood clots. It will make, your healing, if you end up having a C-section, the healing will take much longer. You're at high risk of infections. And also your cardiovascular risk goes up with obesity as well. So try to think of those. Think of any investigations that might be needed prior to pregnancy. So if someone's got any cardiac disease, for instance, it's good to know what is your current echocardiogram. If someone's had an echocardiogram, 5-10 years ago, that's old. You need to get an up-to-date information so that you have a baseline to compare once the woman gets pregnant. And equally, retinal screening in diabetes. So for instance, diabetic retinopathy can get much worse once you get pregnant. So having an up-to-date, retinal examination is good. Same applies to asthmatics. What is your baseline pulmonary function test, or the spirometry and things, because you need to be thinking, okay, as that baby grows, your vital capacity will get squashed. So if you're starting off with a really poor respiratory function, then you need to prepare for that. And if you can change it by optimizing the therapy for asthma, for example, that would be great. And as a result of this consultation, I think, okay, do you need any additional tests? Do I need to write to your specialist to arrange certain tests? Are there any implications for delivery? So for instance, a woman with asthma might get an exacerbation of asthma during labor. So I need to be thinking, of steroids and things beforehand. And also there's implications for once women birth and for the postnatal period. So, particularly with, anticoagulation and things, and I'll talk about that. And also thinking about contraception. So moving on, if we start with some neurology cases. Again, this is not in your booklet, it's part of the presentation. So we have an 18-year-old girl. This is her first pregnancy. She's 16 weeks pregnant, and she was seen by her boyfriend having a tonic-clonic seizure in a festival that they were attending. The seizure terminated on its own. They called the ambulance and she was brought into hospital. So bottom line, if you could, can I see the chat? Can I see the chat? If you tell me your differential diagnoses, can you still see my screen? Chat. If you think, yeah, eclampsia, good. What other things other than eclampsia could be causing this seizure? Epilepsy, very good. So, and I'll go on to the next slide. Let me start sharing again. Yeah, hypo, yes, perfect. Can I minimize this? Go back. So basically, you need to think about the differentials, not just in pregnancy, but what could give you seizures even outside pregnancy. So think of things like epilepsy. Could this be eclampsia? She's 16 weeks. So technically, people don't get, preeclampsia or eclampsia before 20 weeks. Because of the placenta, eclampsia is a disorder of the placenta, and you need a well-established placenta, and that's usually after from 20 weeks onwards. You need to think of other causes. Has she had a stroke, so a cerebrovascular event? Does she have a space-occupying lesion? Remember that pregnancy increases your thrombotic risk, because and could this seizure be a first presentation of a cerebral venous thrombosis? Think of your metabolic causes. So is your blood sugar, is her blood sugar low? Is her sodium high or is it low? Is her calcium high or is it low? Think of infections, so any meningitis, encephalitis, and obviously, well, this it's a cheeky question because it's saying she's in a festival, so you should think about alcohol or drug use, or equally her withdrawing from regular drug misuse. There's something called thrombotic, so TTP, thrombotic thrombocytopenic purpura, and this can be the first presentation. And what I want you to think is, yes, think of eclampsia, and yes, women might get very early term preeclampsia, and slightly before 20 weeks. It's really rare, but also don't forget about the non-obstetric causes of seizures. So what we tend to do here in the UK, if someone's had a first seizure, that we will organize the CT. Speak to the neurologist, try to get to know the medication history of the patient and the social history. If she's known to be epileptic, ask her, like, are you taking your medications? Because as I said, some women will stop taking the medications in fear of harming their baby. And also think that some anti-epileptic medications will require a change in dose during pregnancy. And we'll go on to that on later slides. In epilepsy in particular, if a woman's having seizures at night, that's a red flag, particularly for something called it's called SUDEP, sudden unexplained death in epilepsy. But so having nocturnal seizures is something to watch out for. Anyway, so epilepsy is one of the commonest neurological causes. And here we see 3 to 4 pregnancies per 1,000 pregnancies in a year, and it causes nearly 1% of maternal mortality, but this is double the mortality rate in the non-pregnant state. And I think the key message is preconception counseling is needed. And if a woman comes in with a seizure, and there's a lot of fear of, oh, can I do a CT head and the risk of radiation? But try to think, if I don't do the CT head, what are the consequences of that? So whenever you're instigating a treatment, think, what will I gain and what will I lose? But also, if I don't give a woman an investigation, a test, what is she going to gain and what is she going to lose? So I urge you to think about that. So epilepsy and anti-epileptic drugs, it's just for you to be mindful that your liver and your kidneys get much smarter at more intelligent and much better at metabolizing drugs in pregnancy. So often the medications do need to be increased. Something that we need to tell women is there's a risk of congenital malformation. So if you take your average woman, non-epileptic, there's a 3.5% of malformations. But if they're on sodium valproate, this further increases to 6%. Women on lamotrigine, they've got a very comparable malformation risk to women not taking any anti-epileptics. And it's the same with Keppra. And usually what I say is the higher the dose of the drug and the more tablets you're taking for your epilepsy, the higher the risk of malformations. So what do we do about that? So often the commonest malformations seen are cardiac malformations, neural tube defects, and cleft lip or palate. So usually what should happen in an ideal world is you meet this woman before she gets pregnant. So let's say that she was on sodium valproate or on phenytoin, which are highly teratogenic. So I will write to the neurologist and say, oh, can you change her medication to something safer like lamotrigine or levetiracetam? And then you want to make sure the woman has got this like disease stability after you switch the medication before they contemplate pregnancy. And because you don't want to find out that the switch of medication is not working after they get pregnant, right? And in an ideal world, you want them to be on one agent, but that's not always possible. And always remember to give them folic acid 5 milligrams to all women of childbearing potential on antiepileptics. So yeah, so why might seizure frequency increase in pregnancy or in the postnatal period? Yeah, some women might have poor medication adherence or compliance due to fears of teratogenicity. Your drug levels will fall because your kidneys and your liver get smarter at metabolizing things. And remember that in pregnancy, you've got increased plasma volume, so the drug will be more dilute. And particularly with medications such as lamotrigine and levetiracetam. And then there are special considerations for the postnatal period. So, you know, women will birth, they will be sleep deprived because they've got a crying baby and etc. So remember that sleep deprivation, same as in the non-pregnant state, will lower your risk of seizures. So you know, ask this woman, do you have adequate support? Is there anything we can do to help you once you birth and help you sleep as much as you can? So moving on to cardiac. So it used to be the leading cause of maternal deaths, and it's now number 3 in the UK. And why is this? So let's start with the physiological changes in pregnancy. Well, your cardiac output is increased in pregnancy, nearly 50% actually, but the biggest increase is seen in the first and second stage of labor. Your stroke volume is increased, your heart rate is increased by 10 to 20 beats per minute, your blood pressure dips in the first trimester because of the vasodilatation, and then they will rise again on the second and third trimester. And the oncotic pressure is decreased by 10 to 15%. So let's put this into context of cardiac disease. So think of the women who have got pulmonary hypertension and cyanotic heart disease. So anyone with there's a lot of classifications of heart disease, but it's based on breathlessness. So think of here we use the NYAH class, so New York Functional Association. So women who get breathless just at rest or doing very little, that's often a red flag. Because think, if you're breathless without being pregnant, when you add a fetus and a growing baby, and you know your vital capacity will be reduced as well. So think of women who have got an obstruction on the left side of the heart. So women with mitral stenosis, aortic stenosis, HOCM, so hypertrophic obstructive cardiomyopathy, and women with aortic coarctation. The women that we also worry about are the women who have got Marfan syndrome and their aortic roots dilated more than 5.5 centimeters. And think of women who might have had their first presentation of cardiomyopathy after their first birth. So there's something called peripartum cardiomyopathy, because women might be left with left-sided ejection fraction dysfunction. Okay. going on to next, and so this is a cardiac case. So you have a 42-year-old. She's a para one, so she's had one baby before. She's got a background of type 2 diabetes. And when she booked her pregnancy, so that means when she registered her pregnancy, she had a BMI of 40. So she attends the emergency department with worsening reflux, so indigestion type pain and shortness of breath. She says that the pain's retrosternal, and when she takes antacids back home, they're not relieved. So if you put in the chat sort of your things that could be going on in this woman, and I will minimize so I can see the chat. Chat. Okay. Yeah, aspiration. Yeah, gastro. Yeah, good. What other things might be going on? MI, yes. Aspiration, yeah. PE, very good. So obviously we're going to take a history and examination, but that's a very good. Think about the things that could happen. Oh, sorry, let me minimize. So you'll take a history, you will do an examination, so including, you know, oxygen saturations, blood pressure, pulse. You will do some ECG, and remember that in ECG you get some changes in the morphology of your echocardiogram. So you might see some ectopic beats, but remember that ST depression and T wave inversion on the inferior and lateral leads is common. And you have a deviation towards the left axis. And think about doing a chest X-ray. At least that's the very basics. And then you might want to think, depending on what details you get, an echocardiogram occasionally, you might have to do an angiography and to rule out a PE, a VQ, or a CTPA. So MI in pregnancy, it's got a mortality of 5 to 7%. Non-atherosclerotic cardiac disease is very common in pregnancy, particularly coronary artery dissection or thrombosis. Think of your atypical presentations like this one. So if you think about, you know, people with long-standing diabetes, whether it's type 1 or type 2, you get peripheral neuropathy. So the same way you get numbness or pins and needles on your feet, women might come with what we call the silent MI. So they might not get the chest pain that someone without diabetes would. So think about, oh, I've got that discomfort in the chest, and they're diabetic. Don't forget about to think about silent MI. And you know, if you end up doing an an ECG and a troponin, and they're elevated, and you've decided that this woman is actually having an MI, you can use aspirin and clopidogrel in pregnancy. However, whatever you start the woman on, just think of antiplatelets and anticoagulation in around the time of labor. So the labor or the C-section will need planning if women are on these medications. Heparin can be used. Beta blockers are safe to use in pregnancy as long as you've got a justification. But obviously, beta blockers will vasodilate the coronaries, so it will be very good to treat angina. It's safe to use nitrates. And at the end of the day, if you've decided this woman has got you know, an NSTEMI or a STEMI, and you end up needing to do an angiogram, you need to crack on and do it. I know there's fears about the radiation, but think of what will happen to that mum if she doesn't end up with a stent, or, you know, you need to think about the consequences of your hesitancy to investigate or treat. So you're always balancing, what do I gain, what do I lose from doing an angiogram? So always think about that. And if they need a stent, you need to crack on and do the stent. And if you need to thrombolize them, you need to do that. The only thing that you can't do in pregnancy is give ACE inhibitors or angiotensin receptor blockers. but after the woman's given birth, you might be able to use some of them. Statins, they're usually contraindicated in pregnancy. They're teratogenic and give you CNS defects. But if you feel like someone's got really high triglycerides, you might be able to use pravastatin. So moving on to valvular cardiac lesions in pregnancy. So think of divide them onto stenotic lesions and non-stenotic ones. So in mitral stenosis, so think that mitral valve's going to be very tight. That's you're going to have a lot of backlog of water in your lungs, so they will come in with pulmonary edema. But some of them might be asymptomatic, particularly if they've had mitral stenosis for a very long time. Watch out for tachycardia, because tachycardia is dangerous, because the quicker your heart pumps, it's got less time to fill. Okay. And think of your aortic stenosis. So in the UK, we see a lot of women with bicuspid aortic valves that are stenotic, and these usually present with angina type symptoms. And in these women, we try to avoid hypotension and tachycardia. So how do we manage these women? As I said before, in an ideal world, you want to know that they've got a problem before pregnancy, and you want to see a baseline echocardiogram. And what's the merit of that? Because the women with mitral stenosis, for instance, it'd be ideal for them to have a valvotomy before they get pregnant. But let's say that they're pregnant and it's too dangerous to do a valvotomy. You might think of things to slow down the heart rate, like beta blockers. Yes, beta blockers, they might have the side effect of women having smaller babies, but you need to counsel them. So, I'd like to start you on a beta blocker because I don't want you to get tachycardic, because it will have implications for your heart. Yes, there are chances that your baby might be a little bit smaller, but you will monitor the whatever you might have available, either doing the FSH, the fundal superficial height, or you might, if you've got available, maybe more frequent fetal scans to monitor the growth. But don't get into the tunnel vision. Oh, beta blockers are going to give you a small baby, because if you've got an uncontrolled cardiac condition, that placenta won't be happy, because the blood flow won't get there anyways. So you need to optimize the cardiac management. And in particular, relevance to labor, you need to think about good analgesia. And why? Because being in pain gives you tachycardia. So make sure you give them good pain relief, and try to limit the second stage of labor. So usually what we say is, yes, I don't mind you pushing, but if you're pushing, I don't want you to push for more than an hour, or sometimes half an hour. So you need to put a limit on that second stage of labor, because of the increase in cardiac output. Women with mitral stenosis, you want them to be on the dry side, and women with aortic stenosis, you want them on the fuller side, so more hydrated than dehydrated. Was that a question? I'll carry on. If you've got questions, just pop them in the chat, and I'll answer them at the end. Marfan syndrome, so 80% of women will have a cardiac involvement, either in the form of a mitral valve prolapse or mitral regurgitation. The thing that we'll really worry about is the women who have got an aortic dilated root, because they're at a risk of aortic dissection and rupture. And usually we tell women who have an aortic root of more than 4.5 centimeters not to get pregnant. You advise for surgical management, and then you give them the green light to go and get pregnant. But the risk factors are women who've got basically a dilated root more than 4 centimeters on echo. We manage them with beta blockers. And if for whatever reason they ended up pregnant and they've got an aortic root of more than a 4.5, you don't want them to push, because that would be very dangerous in causing an aortic dissection. So you try to organize a planned birth. So you offer them an elective cesarean section. So tachycardia, sinus tachycardia is very common in pregnancy. And how should we investigate it and with what? So it's safe to do an ECG and a 24-hour monitor ECG. Don't forget to do thyroid function tests and echocardiograms if you detect an arrhythmia. But remember that the commonest arrhythmogenic rhythm is SVT. And if they've got frequent or they're symptomatic, don't be afraid to treat them. Giving them adenosine is safe. Using flecainide and DC cardioversion is always safe. What's not safe is amiodarone. And next, moving on to pericardium cardiomyopathy. So this is defined as a development of heart failure in the absence of known cause and without any explanation prior to the last month of pregnancy. It usually starts in the last month of pregnancy, but it can arise in the 5 months postnatal period. But it tends to be in the first month postpartum. And the symptoms are dyspnea, orthopnea, PND, so paroxysmal nocturnal dyspnea, and some women might present with embolic phenomenon. And the risk factors for them are advanced maternal age, so age over 40, high blood pressure, women from Afro-Caribbean descent are at increased risk, and having many babies before, so multiparity, or having a multiple pregnancy, so a twin pregnancy is a risk factor. And we don't really know what causes it, to be honest, but the definition is after you've ruled out any other causes, so, ischemia, etc., but you've got an unexplained ejection fraction of less than 45%, and dilatation in the 4 cardiac chambers. And how do we treat it? Well, it's conservative management. So we give them nitrates, we beta block them. You try to plan delivery so that you can give them inotropic support and ACE inhibition after delivery. If they're pregnant, you need to deliver them to relieve the heart, essentially. And, some women may end up needing a cardiac transplant. But what I want you to take home is that it's got a high mortality and the recovery is about 50%. So if you suspect it, plan delivery as soon as possible so that you can start with ACE inhibition and the rest of the therapy that I mentioned. And don't forget about thromboprophylaxis because they're at increased risk of blood clots. So if I get someone with pericardium cardiomyopathy, I'll make sure they're on prophylactic anticoagulation with low molecular weight heparin. And once they deliver, they need prophylactic low molecular weight heparin for 6 weeks postpartum. So important messages, don't forget about preconception counseling. Remember that pregnancy can make a lot of cardiac conditions worse. Pregnancy is contraindicated in certain cardiac conditions. Just remember that now women are getting, pregnant much older. So women with congenital heart conditions might be, getting pregnant. Consider older mums and the ones with cardiometabolic disease. And just remember that it might be their first manifestation of cardiac disease when they get pregnant. So considerations of in the labor, just remember that the labor and the first few hours after delivery are the risky time periods. So make sure you get the meticulous fluid management. So in mitral stenosis, remember to write them for them to be slightly on the dry side. And in women with aortic stenosis, to be on the hydrated side. Remember to put a limit on the second stage of labor, so because you don't want women to be pushing for more than half an hour to an hour. And you need to avoid certain medications. Sorry, I thought I had it on the slide. So you need to think of things that will put your blood pressure up. So that are used in the management of PPH, so postpartum hemorrhage. So things like ergometrin will put your blood pressure up. So you need to if you can avoid ergometrin, do that. And instead use oxytocin in a slow infusion. So moving on to respiratory disease. So we've got a 39-year-old who's nulliparous. She's 12 weeks pregnant. She got pregnant through IVF. So this is a very precious pregnancy. And she's come to you with a swollen, painful left calf for the last 3 weeks. She then tells you she's developed sudden onset left-sided chest pain, which is worse on inspiration. She feels like she can't quite catch her breath. On examination, her respiratory rate is up at 34. She's short of breath, just getting undressed. She's tachycardic at 118 beats per minute, but she's normotensive. When you put the oxygen sats probe, her saturations are 92% on air. So what is your differential diagnosis and what investigations would you start? And let me see the chat. Oh, let me scroll down. I'll answer these questions at the end, okay? Yeah, D dimer. D dimer, it's a no, but we'll go on to that later. Just put your answers. Yeah, you're going to use Wells criteria. Very good. Yeah. And what sort of investigation? So someone mentioned a D dimer. Would you do any investigations? Yeah, definitely do a chest X-ray. TPA. Yeah, good. We'll talk onto that. CTPA, is it safe or not? Good, but you got the grasp of things. But you know, I would start with the basic examination. I mean, I tend to order my thought process when I was around exams. You know, things that you would look for in the examination. So look for the asymmetry in the cuffs. You know, look for a sinus tachycardia. You're gonna do, you know, your basic obs, which are there, but and then you're going to move on to investigations. So VQ scan, excellence. Yes, you can do both, and there's pros and cons. My slides are not moving. So, okay, so I've got a little questions here, but I'll move on to next. So who would do D dimers? Who would do leg Dopplers? Who would give her prophylaxis? Low molecular weight heparin? Who would, if you could mute. If you could mute, sorry. Who would give her a treatment dose dolteparin? Who would do a VQ and a CTPA? So the answers are here. So D dimer is false because most women who are pregnant, regardless of a PE or a DVT, will have a raised D dimer. Could someone unmute? Someone's talking. Sorry. Just for the lecture. You're going to do, yeah, so don't do a D dimer because it will be high and it won't tell you anything. So leg Dopplers, definitely do them. It's cheap, it's available, so definitely do it. Prophylactic low molecular weight heparin, that's false. If you suspect that someone's had thromboembolic event, you need to start treating them. You don't wait to for the investigation because you will cause delays and the clot might extend. And don't forget that in pregnancy, we split the dose of the low molecular weight heparin. So weigh the woman, you know, work out the total 24-hour dose. And if it's, you know, a total of 12,000 units, remember to split the dose. So 6,000 in the morning, 6,000 in the evening. So split dose low molecular weight heparin. And you can do both a VQ or a CTPA. And I'll explain that on the slide after this one. So most women will get DVT on the left.
I think you're not sharing your screen. You stopped it somehow. I'm not sure, but you can do anything.
Okay. I'll stop the share and start again. Apologies. Can you see it now?
Yes.
Yes, it's clear.
I'm sorry. Which one was the last slide that you saw? I can go back.
I think it's okay. We catched up, but the last slide we saw was
Okay.
the examination one
And-
with the.
Okay. And I'll make sure you'll have I'll email the presentation anyway. So but yeah, most women will get a DVT on the left because of the basically the uterus will press on the left-sided veins more. So just be mindful of that. However, it doesn't mean that all DVTs are left-sided, but it's just a little bit of knowledge. And in pregnancy, the DVTs tend to be a little bit higher. So don't forget, you know, if you think a woman's got a PE, but you scan their leg, sorry, a DVT, and you scan the legs, and the scan is normal, you know, I would keep them, if that's your top differential diagnosis, keep them on treatment dose dolteparin, but try to repeat the scan 2 days afterwards, because not all DVTs will show up nicely on the first scan. And we'll go on to VQs or CTPAs. So again, if you have a woman who's got normal lungs, so you know, no pulmonary fibrosis, no cystic fibrosis, etc., a VQ scan is better. But if you've got a woman who's got another lung condition, a CTPA is always better. Okay. Ooh. And then let me go on to next. And this is a slide what I tell you everything in a snapshot. So they're both very good, VQ and CTPA scans to detect PEs. They've got a high negative predictive value, so good to rule out, and a high sensitivity. However, I tend to prefer VQ scans in women, like I said, who've got a normal lung parenchyma. However, so they both have got advantages and disadvantages. So the VQ scan will give a higher radiation dose to the fetus, okay? However, the CTPA will have a higher radiation dose to the maternal breast tissue, okay? So they both have got pros and cons. However, I think getting the diagnosis right is very important, because you don't want to anticoagulate a woman unnecessarily. You know, you want to know if they've got a PE or not, because it will have implications for the rest of the pregnancy and for after pregnancy. You know, anticoagulation is not without its risks, and it will have implications for the labor and birth. So at the end of the day, getting the diagnosis right, I think, is more important of the theoretical fears of radiation. The radiation risk is very, very tiny, and the scanners in terms of CTPA, they're getting better at giving less and less radiation. A little practical tip to avoid in real life is don't forget to tell, so in the UK will be a radiographer who administers the contrast for CTPAs. So, and remember that pregnancy has got a higher, you know, cardiac output, etc. So they need to put the contrast in quicker. So don't forget to put on the request, the patient is pregnant, and please adjust your protocol to pregnancy, because we get a lot of, in the UK, there's a lot of non-diagnostic scans because they haven't adjusted the contrast rate going in. So don't forget to mention the pregnancy on the request, so that they can adjust the appropriate contrast rate into the vein. Okay. And think, if someone has got any other chest pathology, you know, tuberous sclerosis, you know, with lesions on the lung, or cystic fibrosis, a CTPA is always better, because it will tell you if there's something else causing the chest pain. The CT will be more informative. So VTE in the UK, sorry, it's not the second, it's the top leading cause of maternal mortality. And think about, yeah, prevention is better than cure. So when you see a woman, assess her risk factors of a PE, and that's something that you do in a dynamic way. You do it in every visit of the pregnant woman. And think about what are the antenatal risk factors, but think that postnatally, you know, your risk of blood clots will also go up. Start treatment if PE or DVT is in your top differential. I would start treatment and do not delay the treatment until you get the investigations. And if someone's hemodynamically unstable and you're really worried, do thrombolyze them, because with, you know, a PE will, a severe PE will cause cardiovascular compromise and, you know, a cardiac arrest, and ultimately that placenta depends on mom's heart and circulation. So if you need to thrombolyze, thrombolyze. What we use, so I urge you all to go to the Royal College of Obstetricians and Gynecologists. There's something called the VTE risk score. So essentially, you've got a list of risk factors that you're always checking every time a woman visits you. But essentially, if you end up with, so each risk factor scores you 1 point, most of them, some of them score you more. But the bottom line, if you end up with a risk score of 0, you don't anticoagulate. Some women will have a risk score of 2. Again, you don't anticoagulate, but don't forget that pregnancy is dynamic, and someone might not have a risk factor when you see them at 12 weeks, but when you see them at 20 weeks, they might have developed risk factors. So this is what I'm urging you to do. Always do the VTE risk score. But let's say that you start off the pregnancy with a VTE risk score of 3. You don't anticoagulate until they're 28 weeks. And when I say anticoagulate, it's prophylactic anticoagulation. I'm talking about thromboprophylaxis, okay? And there's different risk factors. So think about, you know, have you had a previous blood clot? You know, is the patient admitted into hospital? You know, they'll be more immobile if they're in hospital. Have you got any family history of thromboembolic disease? Don't forget about women who have had ovarian hyperstimulation syndrome, particularly women accessing IVF. Those are at high risk of thrombosis. Don't forget the women with high BMI, older than 35, women who've had 3 or more children, women who smoke. And yeah, think that some risk factors are transient. So for instance, what we found in the UK is that there's a lot of women with hyperemesis gravidarum. So they're very dehydrated in the first trimester, and they're at high risk of thromboembolic disease. So don't forget to ask the woman, you know, are you eating and drinking? You know, if you're vomiting, how much are you vomiting? Are you dehydrated? Because if you're dehydrated, your thrombotic risk goes up. So that's the bottom line. So what I want you to take is there's a risk score in the Royal College of Physicians for thromboprophylaxis. So I urge you to visit the website. Okay. Asthma. So when I meet people with asthma at booking at the beginning of pregnancy or in the preconception counseling, I will say, look, 1/3 of you will stay the same, 1/3 of you will get worse, and 1/3 of you will improve. And if women, you know, do become pregnant, encourage them to continue with the therapy for their asthma. If they end up in hospital with an acute exacerbation of asthma, they should get treated as in the non-pregnant state with the same drugs and the same antibiotics. And special considerations with women with poorly controlled asthma. Think if this woman's been on oral steroids for 2 weeks or more prior to delivery, don't forget that they will need cover with hydrocortisone because their adrenals will be affected. So you need to cover them with hydrocortisone during labor. Moving on to thyroid disease. Hyperthyroidism. It's rare, but it complicates 1 in 500 pregnancies. Most women, you'll know that they're hyperthyroid before pregnancy, but don't forget that some women might present for the first time in pregnancy. It's a little bit annoying because the symptoms of hyperthyroidism might mask the ones of pregnancy. So they might be intolerant to heat, they might have palpitations, they might have a bit of tremor. And don't forget to watch out for signs, so such as tachycardia, the thyroid eye signs, the pulmonary erythema. And most women with hyperthyroidism are due to autoimmune disease, so Graves' disease, and they will have thyroid receptor antibody positivity. And why is this important? Remember that antibodies cross the placenta, particularly in the 2nd and 3rd trimester. So what we tend to do in the UK is we measure the antibodies when we meet them at booking, and then we measure them again in the 3rd trimester. And if they're still high, we want to monitor the baby for fetal or neonatal thyrotoxicosis. And this will be transient. The babies will just need watching. Yeah, it's got, so having antibody positivity has got fetal implications. Don't forget that TSH is the structure of TSH is very similar to the beta HCG. So the TSH might be suppressed in early pregnancy because your beta HCG is very high. And particularly women with hyperemesis gravidarum might present with something called biochemical thyrotoxicosis. So if someone's got deranged thyroid function test in the 1st trimester and they've got HG, so hyperemesis, don't forget that this might be a biochemical thyrotoxicosis as opposed to true hyperthyroidism. And sometimes it's very, very difficult to distinguish between both of them. But bottom line is, if you're hyperthyroid, you might notice that your exacerbations might occur very early in pregnancy or very late, okay? So hyperthyroidism, don't forget that poorly controlled hyperthyroidism will lead to a thyrotoxic storm. Both carbimazole and propylphenol uracil are safe in pregnancy. They both have got advantages and disadvantages. They both cross the placenta, but carbimazole more so than PTU. Just tell women, again, this is very rare. So there's a small risk with carbimazole of aplasia cutis in the newborn. And usually PTU is the first drug of choice in pregnancy. But let's say if someone's pregnant and they're on carbimazole, do not switch them, leave them on whatever they're on and monitor them, okay? That's my advice, because if things get better or worse and you have switched the medications, there's no way of telling if the deterioration has been because of the therapy switch. So my take-home message is, if they're on PTU, keep them on PTU. If they're on carbimazole, keep them on carbimazole. But do warn the mum there's a small risk of this and we'll need to monitor baby once they're born. So remember, the downside of PTU, it might cause liver impairment. So the liver function test will need monitoring throughout pregnancy. Just remember, women on either carbimazole or PTU, their newborns might have neonatal hypothyroidism, so they will need watching by the pediatric team once they're born. Thyroid test should be taken on the neonate. Moving on to hypothyroidism, is really rare. It affects 1% of pregnancies. Again, same with hyperthyroidism. There's a lot of overlap with pregnancy-related syndromes, low T4 and raised TSH. There's different ranges in pregnancy, and I will make sure it's included on the booklet that we'll create for you. 25% of women will need a dose increase in levothyroxine. So what I will tell women, bottom line, women with hypothyroidism, you want the thyroid function test done to be done at a minimum of once per trimester. So they will need 3 sets of blood tests. And I don't change the medication proactively. I do the blood test, and then if the TSH is more than 2.5, I then increase the dose of levothyroxine. So if I have someone who's on 75 micrograms of levothyroxine and the TSH is 3, I will say, can you please increase it to 100 micrograms of levothyroxine? And I will then ask them to repeat the thyroid function tests in 6 weeks. Don't forget, with hypothyroidism, the fetus is dependent on the maternal thyroid hormone until they're 12 weeks. And there's an association of with untreated hypothyroidism and infertility and reduced IQ in the neonate. Often you'll find that severely hypothyroid women will struggle to get pregnant in the first place. So just don't forget to check the thyroid function tests once per trimester and 6 weeks after they've given birth. Last but not least, a little bit of cardiac cardiopulmonary resuscitation of the pregnant women. So think of the mum first. So in the UK, we use this acronym called Mrs. MARD, but it's called manual uterine displacement. So if women have got a cardiac arrest and they're pregnant, do not forget to push their uterus towards the left to relieve aortocaval compressions, because they won't get the return from the legs. And again, don't withhold investigations or life-saving treatments. Again, CPR is done as per the usual protocols. Think of intubating these women early because of the risk of aspiration with a gravid uterus. And occasionally, and very sadly, you need to do perimortem cesarean sections. I'm not an obstetrician, so I cannot tell you how to do that. And occasionally you have to do that to improve the circulation to the woman within 5 minutes of the cardiac arrest, if women are beyond 20 weeks pregnant. So I've covered a lot of topics. I'm really sorry that I've crammed a lot.